I was tasked to look at the role of lateral for deformity, and essentially, which one is it? Top one.
I think if you're plugged in.
Yeah, I'm going to plug in. Yeah. Okay. So basically, there's a few goals. So deformity goes with alignment. The two, you can't separate the two. If you want to understand deformity, the first thing you have to understand is alignment. And you have to understand why alignment matters. Why do we care about alignment? After all, patients in deformity have had to live with malalignment for many, many years, maybe even sometimes pre-symptomatically or asymptomatically. And then you have to understand the indications for deformity correction and understand that they are intrinsically linked with indications for alignment correction. Then some pathways for treatment, lateral options, which is the focus of this talk. ACR, I think we've covered it. I'm just going to very briefly give you some statistics on the correction that we're able to achieve. Look at some limitations of the lateral and also the future. I'm going to race through it because we're a little bit behind time, but maybe at the end, if you have questions, we can answer them. So obviously the goals of spine surgery is not just to decompress the neural elements and to relieve symptoms, but it's to stabilize unstable segments. It's to preserve alignment if alignment has been maintained, importantly, but also obviously to restore alignment if there is a deformity. But we shouldn't underrate the importance of preserving alignment in whatever next surgical treatment we dispense for the patient. So alignment means that your head or the head of the patient is over the shoulders, which is over the hips, which is over the feet. It's as simple as that. And when those things fall out of balance, then there is energy expenditure initially by the musculature, by the musculoskeletal system, to keep the patient in this cone of economy, which I'll show you. And past a certain point of energy expenditure, then that is unable to be compensated for, and pain sets in. And you saw the patients, you've all seen them in your clinic, the folks that are unable to or maximize their compensatory system. They typically retrovert their pelvis if they're able to. They bend their knees, and they're able to realign some of their balance by increasing their pelvic tilt. But past this cone of economy, then energy expenditure is made, and that past a certain limit results in pain. So just briefly, we've talked about adult deformity. It is in all three planes, both sagittal, coronal, and combined. We like to understand the etiology of it and to also understand whether it's something that is rigid or we can correct on the table prior to our surgical intervention. So both in terms of demographics and then leading on to classification system, deformity has been examined very extensively. The Schwab classification system looks at the coronal type curves and then as various sagittal modifiers that are impactful on the way we treat these patients. And you'll notice that the modifiers are centered around these spinopelvic parameters, namely looking at the pelvic incidence, its relationship to the lumbar lordosis, the sagittal vertical axis, and the pelvic tilt. And these parameters must come together in harmony for the patient to achieve the global alignment that we need and to satisfy our goals of improving their quality of life based on these parameters. Because we have data which demonstrates that your quality of life is intrinsically related to how well aligned you are, particularly in the sagittal plane for adults. So what is that? What is that loss of global alignment? We start with the SVA, the sagittal vertical axis. We have data which demonstrates that these particular parameters, your ODI, SRS, short form 12 parameters are affected when there is marked positive sagittal balance. In other words, your C7 plumb line is more than 5 centimeters in front of the posterior superior aspect of the sacral end plate. And it's markedly associated with disability. And correction of it improves that disability. There is that data. We also know that loss of lumbar lordosis is also related to our indicators, such as our ODI, our mean ODI, and other parameters such as visual analog scale and so on. And as our kyphosis increases from in the spine from the high thoracic area to the lumbar lordosis, we see an increase in the disability index as well. So lumbar lordosis is especially poorly tolerated when it's lost in terms of disability, its impact on disability. So therefore, what is it that our goals are directed towards? We must aim to preserve lumbar lordosis when it is present and to restore it when it's lost. Again, we want to avoid that sagittal decompensation. Here's one parameter that you should be aware of. When you don't achieve alignment between lumbar lordosis and pelvic incidence, and classically we know that they should fall within about 10 degrees of each other, then the risk of a reoperation to a revision surgery, whether it be for adjacent segment disease or any other parameter surrounding that initial index operation, is increased tenfold. So if you leave with any pointer from this particular lecture, let it be this one. And the implication of that is that even with a single level short segment correction, decompression, stabilization, interbody fusion that you perform, you got to understand its impact on their alignment. I obtain 3-foot standing films on every patient that comes to my clinic. In some situations it's not possible, but at the very least what you can get is imaging of the hips and imaging of the rib cage, so you have an idea of what the pelvic incidence is and what the lumbar lordosis is. It's even more ideal if you can see the whole 3-foot standing x-ray. It's even more ideal if you have something like EOS, where you can see from the top of the skull all the way down to the feet. So basically, to support that kind of argument, there's an article that came out recently that looked at the impact of that PI-LL mismatch on a short segment TLIF. And it basically said that the incidence of mismatch, or the incidence of ongoing disability and need for reoperation, increases when there is a PI-LL mismatch, even for short segment interventions. Here's a study from the Pittsburgh folks, 2017. They looked at the impact on adjacent segment disease. And basically they found that if the mismatch is above 25 degrees, that is 100% positive predictive value on revision surgery for adjacent segment disease. And the odds increased by 1.4-fold for every 1 degree in mismatch. So again, if you leave with any global kind of perspective, you've heard very specific technique talks and impact talks on behalf of the various procedures. But if you leave with any pointer, let it be that you understand that even for your short 1 or 2 level TLIF, PLIF that you perform, you have to take into account the impact on their alignment, at least for that level, if not for their lumbar lordosis and their total sagittal balance. And you can do that because you understand that TLIFs, for example, are typically kyphosing procedures. So your implant is placed anteriorly. You decide to compress once you've achieved a neural foraminal decompression, and those goals are maintained in your planning, even for that operation. So, as I said before, these parameters are important. So the PI and LL mismatch has the goal of being less than 10 degrees based on clinical data that we know is relevant for their long-term quality of life. Secondly, the pelvic tilt, which is something that is influenced by their alignment and is variable. We have the goal of it being less than 20 to 25 degrees. and that sagittal vertical axis being less than 5 centimeters from the C7 plumb line down. The PI is fixed in life past skeletal maturity. And so that is the one parameter that is fixed in this whole equation. But the lumbar lordosis, pelvic tilt, and the SVA are not, and they can be influenced both by compensatory mechanisms and ultimately by the surgery that you provide. Okay, so what's happening to deformity? Well, it's increasing because our population is getting older. So as their life expectancies increasing, as comorbidities are being handled in a better way, as our surgical techniques are improving such that we can effectively treat older and older patients with these comorbidities, the marriage or the interface between older demographic patients and our capacity to treat them is being met on a greater basis. And so this group of patients, deformity patients, will naturally become an increasingly prevalent aspect of your spine practice, and definitely your spine deformity practice. And of course, don't forget that there's, as a result of everything that we've talked about and the failure to abide by that, the risk of iatrogenic deformities is also increasing. And so that's also factored into your future deformity patients. So what are the indications for treating these folks? Well, obviously, you need to treat their pain generators, whether it's neural decompression, dealing with instability, and understanding that they're progressive, the nature of their disease is progressive. But it's not necessarily just for cosmesis. Remember, as we said before, these folks typically have had a small amount of coronal or sagittal, not necessarily imbalance, but scoliosis or kyphoscoliosis early on in their lives. And as the segmental disc height loss has increased and spondylosis has increased over time, this has exacerbated their deformity. The one thing that we've understood based on biomechanical studies, particularly as it relates to spine, is that deformity begets deformity. So when you have an increase in your SVA, when there's an increase in mismatch between your PI and LL, past a certain ability, past a certain point for your musculoskeletal system to compensate for it, for every increase in that mismatch or in that imbalance, then that will beget increased deformity. And this is biomechanically proven. So, of course, there are other functional parameters too that are met with deformity indications, and that is to treat their ability to have improved pulmonary function, for example, and as we said, improve their neurological function. So what are the factors that play in the treatment of that? Number one is, what is their symptom? What is it that you're treating? Are you purely treating a neurological reason for their pain? Do they just need a decompression? If they're in balance, but that is not, they have kyphoscoliosis, but that is not their main issue, then you need to tailor your treatment to that. Secondly, what are the medical comorbidities that they have? Thirdly, what is the flexibility of the spine? In other words, do you need to plan for osteotomies and correction of the deformity other than pure instrumentation? And secondly, and lastly, sorry, can you actually perform the procedure? So the options available, as you've gathered so far, is that one is the traditional open technique of correcting the deformity all through the back, posterior approach. You can do big deformity correction through large osteotomies, such as a pelvic pedicle subtraction osteotomy or a VCR. Some component of it can be done through a lateral approach. We've talked about ACRs and its alternative in terms of achieving hyperlordosis with respect to the rest of the spine. And can you actually achieve a hybrid or even a circumferential, minimally invasive a solution to their deformity without needing to have an open part of their treatment? This is traditional open spine surgery. It results in this. You've probably seen this picture before. The point of this is that it is associated with comorbidity. There is blood loss. There is, Bill's laughing because it's probably been many years since he's done that operation. But you know, for those of us who unfortunately still have to go down this pathway for specific patients, it is not fun. They have an extended length of stay. They suffer through ICU stays, lots of comorbidities, and the University of Washington study that came out in 2011 demonstrated that they had something like a 43% unplanned return to the operation, huge number of neurological deficits, and a significant morbidity as well. So, like I said, it's morbidity, it's risk of proximal junctional kyphosis. You're limited in the population that you can treat here because they should be able to withstand this kind of operation. All your complication profile risks are increased. You have a long recovery. They don't thank you, at least not in the short term. So where did it all begin? It began much earlier than Dr. Lenke, but he began to classify the deformities in terms of surgical planning and surgical thinking. And he also really defined the osteotomies, the large osteotomies that we talked about. And he demonstrated great correction of kyphoscoliosis deformity by appropriate use of those osteotomies in achieving his goals. Then Luis came along and created a revolution by being able to deal with the inner body on a minimally invasive basis. And that became part of the mainstay of treatment for deformity, or part of deformity correction. But can you still correct a whole scoliosis with a lateral inner body alone and nothing else? Reg Hade re-emphasized the importance of the LLIF with respect to the, if you like, anterior column release at L5-S1 and going out laterally. You heard Dr. Smith talk about really dividing the annulus laterally, maybe even taking a pituitary and coming out laterally enough to release as much of the annular fibers as possible, and then being able to implant hypolordotic cage to help achieve that. And then some of our superstars present here today, such as Dr. Uribe, Mundus, Eastlack, Taylor, and so on, really kind of talked about the concept of the ACR and understood the value of ALL release. And you're going to hear more about that in the next talk here. These are Okonkwo slides, and I've stolen them unashamedly because they're such a nice evolution. And then came along Neil Anand that talked about the concept of circumferential minimally invasive surgery. And that is that you can achieve your anterior release through all the techniques that we've talked about, but then you can compress at the back through percutaneous screws and marry these two up to help achieve your deformity goals, and do it all through a minimally invasive basis. And the data on that's coming out, but he's provided some very influential papers where people thought it was impossible to do this. He really came out with early data on the ability to do this, including updates with great results from his practice. So we've talked, I guess we've addressed this in terms of surgical options. So you have your posterior osteotomies, you've got your regular lateral inner body fusion, you can marry that with an anterior column release, you can marry that with a posterior column osteotomy, Smith-Peterson, Ponte, whatever you want to call them. You can add in the ALIF and the anterior column release ALIF, and altogether, these are the options to correct this deformity. The problem with your classic traditional open anterior thoracolumbar deformity was that it was associated with horrible complications, not just pain, but hernia prevalence and functional deficits because of the fact that large incisions were made, no compensation was made for location of those anterior abdominal nerves from the lumbar plexus, and very unsatisfactory cosmetic defects over time. With thoracolumbar fixed sagittal plane deformities, look at PSOs. Look at the complication rate from PSOs. In addition to 5.6% of wound infections, this is from an SRS study that looked at more than 500 patients that were treated through PSOs for their deformity, and the profile isn't great, basically, through these posterior osteotomies. When they looked at 3-column osteotomies in more than 100 consecutive patients for deformity, 87 of these patients underwent a PSO, 18 a vertebral column resection. Major surgical complications exceeded 35% in the PSO, more than 20% in the VCR. These are major complications. So it's not just wound infections and sepsis, but it's neurological deficits and so on. Now, they didn't actually demonstrate an impact on the outcome unless they're permanent, which is obvious. But nonetheless, these are very high statistics, and they're done, by well-seasoned players in the deformity field. So then Juan Uribe came along and he divided these deformities into an understanding of what was mild, moderate, and severe. And this was kind of very helpful, because basically it gave us an understanding of the surgical planning required to achieve our goals. So in the mild patient, the mismatch patient or not mismatch patient, where PI and LL are matched below 10 degrees, really the goal is to maintain that alignment and not to lose it. In those that are moderate, then your surgical planning and treatment has to be planned in order to achieve some degree of lordosis correction and SVA and correction of the pelvic tilt and so on. But when you're severe, you're dealing with a rigid curve, and you really need to plan large osteotomies, which may have to include some degree of posterior column osteotomies in addition to the anterior options, the lateral options that we've given you. So what are the benefits in going lateral for deformity correction? Obviously, it's safe. Based on all the data that you've seen so far, it is reproducible. It's clearly minimal muscle damage and soft tissue damage. It's exceeded results with respect to comparison with posterior options. And you can combine it with any number of posterior instrumentation options, such as percutaneous screw placement, to reduce the number of levels that you require. So let's look at some data on this, and we'll get through this really quickly. Some of this is early data, but in Juan's early data, he demonstrated improvement in disability index and VAS scores. His anterior thigh numbness rate was 12%. I'll just remind him back at that time. But Juan, you were 12% at some point, So then the Pittsburgh guys demonstrated that they were able to really improve other spinal parameters, such as the VAS, significantly as well by combination of pedicle screw instrumentation with the lateral, but they still had up 75%. That's extraordinary. 75% thigh paresthesia, dysesthesia. If anything, this is a 2010 paper, so it really shows you the evolution of this procedure. Then Greg Mundus and Akbarni and others looked at those patients, looked at segmental correction through lateral interbody fusion, and looked at it for scoliosis, where the coronal Cobb curve was more than 30 degrees. Over 2 years, the curve improved from 47 to 19 degrees where lateral was employed. Tilt improved at L4, curve at those segmental levels improved as well. And you can see these segmental improvements on these diagrams here. So the point here is that there is a significant improvement, at least in coronal correction, with a lateral implant alone. With sagittal, there is some degree of sagittal improvement. However, when it's combined with posterior column osteotomies and posterior compression, and or if not osteotomies in general, you can improve your sagittal balance. So lateral has treatment for both coronal and sagittal correction needs. And in these patients, they had 50% thigh symptoms, but there was no other injuries in their group. So what about the ACR? So by itself, like I said, there is some minimal improvement in lordosis, maybe about 4 to 5 degrees of improvement. If you combine that with your posterior column osteotomy, where you are able to remove the facet joints completely and then compress, that is a dramatic impact, particularly if you've placed your cage in an advantageous position, and we're going to talk about that in the next session. But ACR, just as an alternative itself, can give you up to 27 degrees of correction if it's supplemented with posterior alignment, posterior correction. So this is a case. This is one of our cases, 65-year-old lady, L2 burst fracture. She'd actually had a hook and screw construct performed outside. This was for a motor vehicle accident. She came in with a significant mismatch of about 40 degrees here. And look how positive she was. And we corrected her. We actually did a incidental anterior column release here at 2-3, but we'd also done a pedicle subtraction osteotomy. And I want you to focus on this. The amount of correction achieved from the pedicle subtraction osteotomy in our hands, and you can argue that it was inadequate, was significantly less than that achieved by the iatrogenic, unplanned for ACR at that level. And most of the correction came from the ACR and the ALL release, not from the PSO. And she achieved balance as a result of this. This is another one, 77-year-old female, coronal imbalance, spinal cord stimulator, which wasn't helping her. Clearly, she has some positive sagittal balance as well, preoperatively. And multi-level lateral instrumentation placement with posterior fixation and compression corrects all of those parameters. I want to talk about the future a little bit. We've talked about ACR. There is a thought for the application of a pedicle subtraction osteotomy through a lateral approach. This we have done in a cadaver, and we've combined that with percutaneous screws. And you can take a perfectly normal spine and make it even more lordotic if you wanted to. But seriously, robotics is probably the next stage that's coming down the pipe with respect to planning for navigation, but also then execution as well. So in summary, alignment is everything, even for single level cases. The goal is to achieve those spinal pelvic parameters, to get your patients within those parameters so they reduce energy expenditure and therefore reduce their pain generation. You've seen the impact of posterior approaches over time, including large 3-column osteotomies. But the data shows the lateral is a safe and less invasive procedure to achieve deformity correction, whether it be through anterior release in the lumbar spine, in combination or alone. And complications are significantly better tolerated than your large open osteotomies, but we still need long-term data. Thank you.